Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. It's quite a long procedure this, in total just shy of 42 minutes. And in reality, the patient was at the clinic for about an hour because there are moments when we're coming out the ear to unblock the tube. Obviously, we take our history prior to treating the patient. Unfortunately, this patient arrived just before my lunch break. Otherwise, I would have run into clinic and there would have been a delay with subsequent patients. So this patient was an extremely challenging case. They have this very soft, fudge-like textured, almost like butter texture wax, but I would say it's probably more keratin dead skin. And this consistency makes it very difficult to remove. They do have underlying otitis externa. So I believe this to be Eczematous otitis externa. So it's when there's Eczematous otitis externa can occur due to an overactive immune system, which then leads to inflammation, and inflammation then causes the skin lining, not only the ear but other parts of the body, to overproduce new skin cells, which then in turn means more skin cells are shed at the surface on the outermost superficial layer of skin. So the skin is continuously replacing itself in the ear. You've got the stratum corneum, which is the most superficial and visual layer of skin, and underlying that on the bony part of the ear canal, the remainder of the epidermis, you've got 4 different layers. You've got the stratum granulosum underneath, which produces keratin and packages it in granules, and also it produces lipids and also secretes the lipids onto the surface of the skin, and that lipid barrier helps to keep all the surface skin cells together. It's almost like a bricks and mortar. So the individual skin cells at the surface are surrounded by this lipid membrane, hence the brick and mortar analogy. And it also provides some waterproofing the lipid layer, so it helps the underlying layers of skin to retain its moisture, and it also helps to expel and repel external water. And then underneath that, you've got some other layers of skin. This stratum spinulosum is that's what gives the epidermis layer of skin its structure, its strength. And then you've got the basal layer where these skin cells are born. So the skin cells that are on the surface of the ear canal, they all originate from the deepest layer of the epidermis, called the stratum basal layer, where they reproduce, and the daughter cells, the cell that's been reproduced, is pushed upwards into the stratum spinulosum layer, and then that's pushed up into the stratum granulosum layer. So at each stage, this skin cell is undergoing changes, particularly in the stratum granulosum layer, the second but top layer, where the skin cell is actually self-programmed to start dying. So the nucleus begins to die, all the internal organelles, so within the cells, begins to die, and instead the cell starts to fill itself with keratin granules, and also these the lipids that I discussed, and also some natural moisturizing factors. These are predominantly acids, and they are very important eventually when they're released in the outermost layer of skin, called the stratum corneum. So the outermost layer of skin, it's full of keratin. So keratin, it is hydrophobic, but I was just doing some research on this, and it's apparently 40% hydrophilic and 60% hydrophobic. So it's not completely hydrophobic. It does allow some water absorption, but not a lot. And then you've got the main function of the keratin is obviously to help repel water, excessive water, but it provides a sturdy outer layer of skin. It gives the skin cells at the surface some strength and rigidity, and it's also reflective of harmful UV rays that may otherwise cause some damage in the deeper layers of skin. And also contained in this outer layer of skin, in the cells, these natural moisturizing factors that were also packaged in granules, they're released. So the outer layer of skin, it's quite amazing. It's extremely, there's a fine balance to be had. The skin doesn't want to over-absorb water. Therefore, it's got keratin to avoid that from happening. And you've got this lipid capsule underneath that's released by stratum granulosum level. But then it's also got these natural moisturizing factors, which are hygroscopic, so they absorb and swell, they're hydrophilic. So it's a fine balance to have. We don't want the surface of the skin to be completely void of moisture, because otherwise you'll get dry, cracked skin. But if you have too much, what happens is that these natural moisturizing factors, so uric acid, carboxylic acid, free amino acids, they are water soluble, so they actually dissolve in the excessive water, which then means that skin cell is void of these natural moisturizing factors. So what can then happen is one of two things. At that particular stage, when these natural moisturizing factors have been leached and dissolved, there's so much water in that skin cell that it then overhydrates and it bursts at the membranes. So you get maceration of the skin. Alternatively, if you recover from that, that individual skin cell is then no longer able to attract any moisture whatsoever. So you get very dry, cracked skin. And obviously excessive water, it also washes away that lipid barrier. Especially if it's warm water, it can leach that away. I mean, I get problems with very dry skin every time I shower, which is daily, on the side of my lips. So if I use facial soap, it washes away the natural oils I have on either side of my lips, and within minutes of coming out of the shower, the skin in that region becomes very dry, to the point where it can start cracking. So when I'm talking or eating, I can physically, it can open up. So I have to use moisturizer daily on that region in particular. And what that moisturizer does, it just helps provide a lipid, alternative lipid membrane. So obviously my skin is not producing enough natural lipids in that region, or they're easily getting leached away when I wash my face with warm water. So I'm artificially replacing that with moisturising cream. And what that moisturising cream does, it locks in internal moisture, because the lipid cream is hydrophobic, and it also helps to stop the skin getting macerated by repelling external water. So it's a very fine balance within the ear. And with Eczematous otitis externa, so with the additional inflammation, your ear is just producing more and more skin cells, and these skin cells are then getting shedded at a quicker rate at the surface. The skin can't, at an adequate rate, expel and migrate the skin. So the skin that's producing the ear canal all originates from the centre of the eardrum. That's the progenitor site. And these outer layer skin cells, these epithelial skin cells, then go on a journey. We call it the lateral epithelial migration. So it migrates from the centre of the eardrum radially to the sides of the eardrum. Think about dropping a pebble in a pond. You get those ripples. Imagine those ripples being dead skin cells on the surface of the eardrum, extending radially outwards. And then those skin cells then line the ear canal and eventually work themselves out towards the entrance of the ear. And this rate of migration is around 1.5 to 3 millimeters a month. But when you've got excessive skin cells being formed, the ear can't naturally migrate them quick enough, so you get this build-up. And then this build-up of keratin in this dead skin cells at the surface, it can become very mushy as it wilts away. And what's happened here is that there's an overproduction of dead skin cells, but also a very adherent inner layer. So hence why it's very difficult to remove, because the consistency doesn't help, but it's still semi-attached to the canal wall. It's not completely desquamated skin. So desquamated skin is the skin that's shed. It's released from the surface. This skin is still somewhat attached to the inner layer, and that's the difficulty, because especially on the bony part, the ear canal, this skin is the skin that's lining the canal. It's less than 0.1 millimeters in thickness. So you can imagine how sensitive that bony part of the ear canal is. You don't have the dermis layer, you don't have the subcutaneous layer full of adipose fatty tissue, and that's what gives the skin normally its buffering effect. So the skin on the cartilage portion, we can apply a bit more pressure. Cartilage is itself flexible, it's not rigid like the bone, but it's protected by a thick layer of skin, which has got a thick fatty layer, the subcutaneous layer. So that provides some protection. The skin on the inner 2/3 of the ear canal, it's like the skin on your shin or your elbow. It's very thin, and contact can be very difficult, and the patient did find it uncomfortable on a couple of occasions. Now, whenever we're performing any procedure in the ear, my ultimate game is to ensure the patient can hear again. Hence why I'm trying to clear the centre so the eardrum is visible. If by removing the side parts of the canal assist in the removal of the wax or skin, in this case, off the eardrum, then of course we'll target that. But as you can see, and you will continue to see, the removal of the skin from the side has no bearing on removing the skin off the eardrum in this instance. So I'm just trying to clear the eardrum now. So we can see the majority of the eardrum. We've got some bits in the inferior anterior recess. You can see I'm very gently approaching this. And that's because this patient has got a bit of a narrowing, which is not visible at the moment because of this layer of kind of fudge caramelized kind of skin. It's hard to really appreciate how thick this layer is and where the surface of the ear canal is. If I go gung-ho, then I'm going to make contact with the canal wall. So I think that was the major challenge, knowing how thick this layer was, knowing where the bone is underneath. You know, if it had X-ray vision, I can see through this and I can see exactly where the surface of the bone is, then it'll make life a lot easier because I know how much wriggle room, how much tolerance I've got when I use the suction probe. Don't want to be using any other instrument here if possible, because even with the right correct, I'll be gliding on the surface of the bone, which again, it's not going to be a nice sensation. So with the fine end, the suction probe that I'm using, we're trying to minimize contact with the canal wall. And occasionally I did make very mild contact, but the patient was able to feel it. So here you can see how thin this is. And I'm just trying to get underneath, and I've been using loads of drops just to kind of almost get underneath. And it's a wafer thing. This is magnified probably tenfold on screen. So the reality is that it's so thin. In terms of the width of the ear canal, obviously it's massive variance between individuals, but on average, and it varies at different points within the ear canal, but on average it's around, you could be forgiven to say it's about 6 millimeters wide, and the average height is around 9 millimeters. And again, the ear canal is not a straight tube. It's got quite a few bends and twists. So when you insert an instrument in the ear, it's not a straight. You're not putting it straight in the ear. You're having to use the instrument and the endoscope to manipulate the outer third of the ear canal to straighten and align the ear canal. So you can imagine when you enter the ear, the first half a centimetre is a straight line, and you have to go upwards. And that initial entry into the ear, we call that the pars externa. So we're talking about the left ear here. So you're going into the ear canal, and then you're going upwards slightly, because the ear canal is slightly upwards inclined around 32 degrees. So that initial entry is called the pars externa. Then you have to stop, because if you continue to go in a straight line forwards, you're going to bump into the second bend of the ear canal. So then you have to rotate around 45 degrees. And in the case of the left ear, that's to the right. And then you go forwards a further, about a centimetre, I would say. And as you're going forwards another centimetre, you also have to continue to go upwards, because the ear canal's still in an upwards incline trajectory. Then after about a centimetre, you have to stop again, because if you continue, you're going to bump into the posterior, the back part of the ear canal, so the right-hand side in this case, which is going to be painful. And if you continue to get upwards, you're going to hit the roof of the ear canal, which again is going to be uncomfortable. So then you have to stop, and that region, that journey, that mid-journey is called the pars media. The final journey is that you then have to come back on yourself. So I mentioned when you initially go in with the pars externa, you stop and you have to turn, rotate right around 45 degrees and travel up in that kind of direction. You then have to stop and almost go back on yourself and kind of rotate yourself back to the left again by almost 45 degrees. And that's where the eardrum is. And instead of going upwards at that stage, you actually go downwards inferiorly, because the ear canal, after that stage, that section of the ear canal is almost like the peak of the mountain. Then it actually travels downwards. So, and that final stage is called the pars interna. Now, if the ear canal was a complete straight tube, it will make life a lot difficult. So what we have to do when we remove earwax, whether it's with an endoscope or when you're using a specular, you're using the endoscope in this case to stretch and straighten the outer third of the ear canal. And it's limited of how much you can do, but it's possible because it's made up of cartilage and dense fibrous tissue. If the outer third of the ear canal was made up of bone, then that's rigid. You're not going to be able to straighten that, and it will make life really, really difficult. So fortunately for ear specialists, the outer third of the ear canal is semi-flexible, not fully, so we are still limited. So we're having to go into the ear and navigate around these two bends at the entrance, so the first and second bend. And it's the first and second bend which gives the ear canal its S-shaped configuration or sigmoid shape. And then at the same time, you're having to insert the instrument as well and navigate those bends. And you've got two instruments in the ear. You've got the endoscope in one hand and you've got the instrument in your dominant hand normally. And obviously they're coming from different angles. You can't both go insert them into the ear canal at the same angle of incidence. They have to go in at different angles and different heights. So when I put the endoscope in, I'm positioning it to the floor of the ear canal. Because remember, the height of the ear canal is greater than the width. So we want to use that to our advantage. So the endoscopes are always below. And in the case of the left ear, I've normally got the endoscope positioned around 4 o'clock, because that's the way we have to push the cartilage, the outer third, to the right to kind of straighten the ear. And then with the instrument, I'm coming from a higher angle, kind of almost downwards. And we have to make sure the instrument is always on top of the endoscope. If they become side by side, they clash and they cross over and you just lose control. And you can't go underneath because obviously the endoscope's in that position. And quite often I'm also using the endoscope to further stretch and straighten the ear canal. So we're doing multiple things at once. We're not only stretching and straightening the ear with both the endoscope and the instrument, we're also then having to make sure the endoscope is in the correct position to visualize the wax. We're just not using it as a crowbar or a doorstop. We're then having to simultaneously direct it so you can visualize and go forwards and backwards. And similarly with the instrument, not only are we using it to stretch and straighten the ear canal, we're also then using it to physically manipulate the wax. So it can be, some cases can be really, really difficult, and this is one of those, not only because of the angulation of the ear, the geometry of the ear, but also because of the consistency, and because it's still strongly adhered to the canal now. Spoiler alert, I'm not going to remove every little last speck. And if truth be told, even at this stage, I'm pretty happy the patient could hear significantly better, but I wanted to get as much out as possible because no doubt this patient's going to be a regular patient. They're going to have to have their ears clean on a regular basis. So I think when they've got this kind of condition, it is quite chronic, and there's things that can be done using moisturizers, but using them in the ear is quite difficult. Steroid creams, but of course you can't overuse those. The main thing this patient can do is keep their ear clear of water, because water can, as I said, macerate the skin. When you've got eczema of the ear already as well, the surface, the stratum corneum, that outer protective barrier, they're not interlocked as well, so water can penetrate through the outer epidermis, and then in the case of the bony part of the ear canal, it can come in contact with the periosteum. The periosteum is the lining of the bone, and it perfuses the bone. It provides the underlying bone with the blood supply that it needs, with all the nutrients, the oxygen, the nerve supply. So you can then develop an infection of the periosteum called periostitis, and eventually it can infect the bone. So there's a lot of things that can go wrong actually. So the ear is just unique in that sense, where I think it's the only skin-lined cul-de-sac in the body. So and the outer layer of skin is made up of the eardrum is actually made up of skin, and that poses a problem because in any other part of the body, when you've got dead skin, it's either desquamated naturally, so the skin sheds off the surface of the skin naturally, and that's just our skin's programmed to do that in normal conditions. Or it's exfoliated, so you can use chemicals to remove that outer layer of the stratum corneum. So those cells that live at the surface are called corneocytes. But in the ear, the skin cells can shed, they can desquamate, but where do they go? You don't want these skin cells collecting in the ear, because if they do, they block your ear. And this is what the problem this patient's having there, because of their eczema in the ear, they're having too much skin being formed, which means too much skin being shed, and the ear can't naturally shed its and well, it can shed it, but it can't migrate it out the ear quick enough, so you get a build-up. And remember, earwax is generally produced at the outer third. So earwax is a cocktail of dead skin cells, so these corneocytes that have shed off the surface of the ear canal. It's also a mixture of sebum, which is the lipid oily secretion produced by the sebaceous glands, which connect to the hair follicle. And so sebum is similar to the oily secretion we have on our scalp. And it's also a mix of cerumen, which is a secretion of an oily sweat from the ceruminous glands, which are modified sweat glands called apocrine glands, which are also found under our armpits and inner groin regions. So these glandular secretions from the sebaceous glands and ceruminous glands are made on the outer third where there's hair. And you don't get hair strands on the bony part because the hair strands need to connect to the dermis layer. The inner 2/3 of the ear canal is void of the dermis layer. It's void of the subcutaneous fatty tissue layer. So these secretions should only be found on the outer third. Now, given some of these secretions will dissipate, spread along the whole surface of the canal wall and eardrum, but it'll be concentrated at the outer third. And then you've got this dead skin that's shedding off the eardrum and then slowly migrating towards the entrance of the ear. And these individual skin cells actually start to shed when it approaches the outer third. So these individual skin cells then mix with the sebum and the cerumen secretions to form earwax. So whenever you're seeing stuff like this deep in the ear, like in this patient, it's either the earwax has been pushed in, or it's not technically earwax, it's dead skin, keratin. But obviously in a different structure than your normal dead skin, because it's still semi-attached, as you can see. And it's the worst consistency, very fudge-like, very like butter. It's the best way I can describe it. And you can see the underlying skin is slightly inflamed. Now, is that because we've been peeling off the skin? Possibly, but even in regions that we weren't peeling off the skin, it is quite red. So again, there's evidence there of some eczema of the ear. Now, this is on the posterior canal wall. We're just going to peel it downwards now. The ear canal is innervated by various nerves. Where we are now in this region, so the back upper portion of the ear canal, it's stimulated by the facial nerve, the seventh cranial nerve. The bottom lower section of the ear canal is innervated by a branch of the vagus nerve called the Arnold's nerve, and the front entire section of the ear canal is innervated by the auricular temporal nerve, which is a sub-branch of the mandibular nerve, which itself is a branch of the trigeminal nerve, the fifth cranial nerve. And they can all have interesting clinical relevance in the ear. Now, The facial nerve, the seventh cranial nerve, actually runs, it's got a branch called the chorda tympani, which runs right behind the eardrum. And sometimes you can actually visualize that when we perform otoscopy. It runs adjacent to the three bones. And that chorda tympani, it actually connects to the front two parts of your tongue, the anterior 2/3 of your tongue. And that provides it with the taste sensation. The facial nerve, the main branch, also runs through the internal auditory meatus, which is a cavity very deep in your ear, beyond the organ of hearing, the cochlea, and also housed in that internal auditory meatus is the eighth cranial nerve. So the eighth cranial nerve is your auditory and vestibular nerve, so your cochlear-vestibular nerve. So it's a combination of the balance nerve and your hearing nerve. Now, sometimes you can develop a lesion of the facial nerve, in part because you can develop a tumour, a non-cancerous tumour called an acoustic neuroma, or the proper term is a vestibular schwannoma. It actually grows on the vestibular parts of the balance section of the auditory nerve, the eighth cranial nerve. And if it grows, it can then compress against the facial nerve. And if it compresses against the facial nerve, it can lead to hypoesthesia, so numbness of the back upper portion of the ear canal. Nowadays, an acoustic neuroma is generally diagnosed by an MRI scan, but historically, pre-MRI scans, ENT consultants would palpate the back upper portion of the ear canal. And of course, under normal circumstances, the patient would feel that and it would be quite sensitive. But if you've got an acoustic neuroma and that back upper section of the ear canal is numb, so hypoesthesia, it can suggest that you've got an acoustic neuroma. So it used to be used as a diagnostic test, and that it's called Hitzelberger's sign. The lower back portion of the ear canal, as mentioned, is stimulated by the Arnold's nerve, which is the auricular branch of the vagus nerve. Now, the vagus nerve connects the brain to your heart, to your cardiovascular system, so it's involved in your breathing as well, your heart rate, but it's also linked to your digestive system. But the vagus nerve is also active in your common reflexes, so coughing, sneezing, vomiting, for example. And also, it can have some innervation to the lacrimal glands, which are like tear glands in your eyes, although that in part is also stimulated by the facial nerve. But when you palpate, when you touch, so it's very relevant when you perform earwax removal, when you touch the back lower section of the ear canal, you can elicit what we call the vasovagal response. And patients, and the response works in different ways. Most common response is the ear cough reflex, or the gag reflex, so patients can cough. But patients can actually become very lightheaded and even faint, because in some people, when you elicit the vasovagal response, the heart rate reduces, the blood vessels dilate, which ultimately leads in a lower blood pressure. So your brain's receiving less blood and you can actually pass out. I've had it happen to me 5 or 6 times, I think, and I had it twice in 1 week, which is quite scary. The first time it happens, it is quite daunting. And patients completely pass out, and they have no control over their weight as well, so they can fall over on the chair. And what we try and do is position them and ideally lay them down and just lift their legs above their heart, so you're trying to get the blood rushing back to the head. But it can be a scary few minutes. Patients, when they come around, they don't know what's going on, and like, well, why am I laying down? What's happened to me? So it is something that can occur when you remove earwax, especially when you're where we are now. This is the part of the ear, the posterior inferior canal wall. Patients can feel sick. I've had that once or twice. The most common one is the gag reflex, or the eyes can become a bit tingly and watery, which can also happen. Um, the ear can also experience a lot of referred otalgia, referred pain from all these nerves. The front part of the ear canal, as I said, it's a sub branch of the trigeminal nerve, the fifth cranial nerve. So quite often you can get referred pain from the trigeminal nerve into the front part of the ear canal. That also stimulates the tragus, which is the flap of cartilage just at the entrance of your ear, and the outer half of the auricle, the pinna, the cartilage on either side of our heads. The facial nerve itself also stimulates some of the concha bowl. So the concha bowl is the bowl, external bowl, and the pinna. So the pinna is, or the auricle as it's known, it's a satellite dish we have on either side of our heads. And the main bowl, the midsection, that's stimulated by the vagus nerve. So again, by palpating that, you can elicit the gag reflex. But it's also partly stimulated by the facial nerve. And if you develop shingles, so an infection of the facial nerve, and that's actually called it's the Ramsay-Hunt syndrome. So it's the remanifestation of the dormant chickenpox virus. So it can become active later on in life after you develop chickenpox in your younger years, and it can cause shingles of the facial nerve. So the proper term is given as herpes zoster oticus infections. It's a viral infection, and that can lead to a rash developing on the concha part of your ear. It's more of a vesicular rash, so you get these like protrusions, little vesicles, little bumps filled with fluid, and it can be quite painful. And patients can often also present with facial paralysis, because the facial nerve also stimulates the muscles involved in expression, so smiling, for example. So you can get a droopiness of one side. So the nerves actually are a really, really important part of when you perform earwax removal, because you need to know what's going on. And when patients present with symptoms, you need to know what's also going on there. Now, the facial nerve is also connected to a muscle called the stapedial muscle, which is a muscle that's connected to the stapes bone. So the stapes bone is the smallest bone in the body, and it's the final bone of the three that links the eardrum to the organ of hearing, the cochlea. And in response to loud sounds, it's an automatic reflex. The facial nerve stimulates the stapedial muscle, which causes the stapedial muscle to contract. And when the stapedial muscle contracts, what it does, it stiffens the three bones, the three ossicles, and we call that ossicular fixation. And when it stiffens the three bones, it makes the eardrum extra stiff, extra taut, which then causes the eardrum, as opposed to emitting sounds, allowing sounds to enter, it actually causes the eardrum to reflect sounds. And these are normally loud sounds. That's when the reflex occurs in response to loud sounds, and mainly low frequency sounds. But if you've got a problem with the facial nerve, so if you've got a lesion there or an infection of the facial nerve, it can inhibit the stapedial muscle, and it stops the stapedial reflex, also known as acoustic auditory reflex. So patients with an inactive stapedial or acoustic reflex can become very sensitive to loud sounds, because the eardrum's no longer functioning, it's no longer reflecting away these loud sounds. And the ear does that on purpose, because it wants to avoid acoustic trauma. You don't want excessively loud sounds entering the cochlea, because it can damage the sensory hair cells. So it's a self-preservation reflex. And of course, we don't want sounds to be uncomfortable for the individual. So that's another important clinical factor about some of the nerves that are located in the ear canal. So sorry to digress a bit, but I just thought I'd discuss that, because I've not really discussed that, and there's only so much I can really talk about in terms of earwax or dead skin, and Also, we discussed this particular case in quite a lot of detail earlier about the Eczematous Otitis externa. So I thought I'll discuss some other things with you. So hope that wasn't boring and it was in part slightly interesting. Now, we're nearly finished now. To be honest, the patient can hear, but you can see this underlying skin. It's very dry on the underlying skin and it's inflamed. So I've just had to put some drops in just to help me peel away these last layers. And there is a bit posteriorly. Now, I actually did stop. I didn't get all of it out. Number one, it's a bit uncomfortable for the patient, but they did have some of the gag reflex. They were coughing slightly, which then obviously the patient coughs during the procedure. You're in there with sharp instruments. It's not good. So I decided to just stop at that stage. And this drops that I've used, they're just now I did use sodium bicarbonate drops. I wanted to avoid using these drops because they can further dry the skin, unfortunately, because they are water based and they are also alkaline. But the olive oil drops weren't working. But what's important is that obviously I'm getting this out almost immediately, so I'm drying the ear. We did advise some acetic acid spray afterwards just to reacidify the ear. And even with the eardrum, you can actually see that outer layer of skin. Now the outer layer is well, I've got a few more minutes, so I'll just describe the anatomy of the eardrum. So the eardrum is 3-ply thick. You've got the outer layer called a cuticular stratum. You've got the innermost layer, which is called a cuticular. That's called a stratum, mucous stratum. So it's lined with the mucosal skin that lines the middle ear, so it's mucous stratum. And then the middle layer is called fibrous stratum. And so the skin that lines the outer lateral surface of the eardrum, the cuticular stratum, is the same skin that lines the bony part of the ear canal where I'm working now. And in fact, the skin that lines the bony part of the ear canal originated from the center of the eardrum, the umbo region. And you can see the skin there. It's just got this macerated look. So I did ask the patient whether they're getting water in the ear. I can't remember if they did or not. But I've got a feeling that in addition to this eczema, they have been getting water in the ear, which makes matters worse. We think water can hydrate the ear, and initially it does. The skin cells, as I said, there's natural moisturizing factors, absorb the moisture. But then if you have excessive water, the skin cells then burst at the membranes. They can't contain all the moisture, and we call that, and it obviously softens the skin. It makes it soggy, and that's where the term maceration comes involved. So it's just got this macerated look, especially on the eardrum. So we've just got this back part of the ear canal now. Interestingly, the back section of the ear canal, so if we're looking at the cartilage portion, the outer third, it's not fully cartilage actually. This part is made up of dense fibrous tissue, and so is the roof of the ear canal near the entrance. But otherwise, the remaining outer third of the ear canal is made of cartilage, and that cartilage is the same cartilage that forms the cartilage of the auricle, the pinna, the external visible part of the ear. So again, you can just see how dry the skin is underneath. So again, just using the fine end. The fine end allows more precision work compared to the full Zollner suction probe. So the diameter of this fine end, it's about 1.4 millimeters, I think, diameter. That's the outer diameter, and the internal diameter, I think it's probably a bit less than that actually. I think it's 1.28, and the internal diameter is just around a millimeter. Whereas the full Zollner suction probe, it's a 14 gauge, so that's around 2 or 2.1 millimeters, with an internal diameter about 1.6 or 1.7. So we're working in millimeters when it comes to the ear. There's not a lot of leeway there. You can see the skin, you can just see how dry it is. You can see those creases. So this underlying skin is void of the moisture that it needs. So again, I'm just assuming this patient did get water in there, and it's then led to a drying of the skin. Of course, when you've got eczema, the outer layer of skin, the stratum corneum, it's weakened. The individual bonds between the skin cells. So the stratum corneum, that itself has about 10 to 30 layers. And the deeper layers of the stratum corneum, you've got these individual skin cells and corneocytes, and they are flat-shaped. So the term squamous describes the flat-natured shape. So squamous is Latin for a fish scale, and they're interconnected, almost like medieval body armor, and there's little connections between them. And then on the more layer sitting on top, these connections slowly become weakened, partly because they mature, so they just weaken because of they've been there for a while, but water can break that down by hydrolysis. There's also certain enzymes that are released by these skin cells that can help break it down. And with eczema, these individual bonds have weakened, so it just makes the outermost layer of skin very fragile. And when it makes it fragile, you get leakage of internal moisture out, so it evaporates on the surface. And then it can also allow bacteria and fungi to penetrate the space in between. But there's a little bit there, but I am happy with that. The patient was getting a bit uncomfortable with that region and also coughing slightly. But I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.